for the introduction. Good morning, everybody. As you mentioned, my name is Mark Schall. I'm a recent graduate of the University of Iowa's Department of Mechanical and Industrial Engineering, where I focused on occupational ergonomics. And I recently accepted a faculty position at Auburn University. So I wanted to say that this was my first Runny Nose conference. I'm fitting in, yeah. Today I'll be discussing a project that we recently completed at the University of Iowa that's really focusing on characterizing muscle activity in ophthalmologists who are performing their basic clinical activities. A little bit of background. The healthcare and social assistance sector of the National Occupational Research Agenda is one of the fastest growing sectors of the United States economy. With over 19 million workers, roughly 13% of the total U.S. workforce, we can see that in comparison to some of the other industries, healthcare has seen a growth since 2007 of almost 11%, where other industries have actually seen an overall reduction of 3%. So it's a growing field, and one of the large issues that we face in this field is the high prevalence of musculoskeletal injuries. In particular, ophthalmologists, or eye care physicians, report a high prevalence of musculoskeletal pain. And typically, the neck and the shoulder region is a high area of concern for them. In fact, we've recently done some research suggesting or indicating that ophthalmologists report more musculoskeletal pain of the neck and shoulder region than other faculty in say, family medicine or internal medicine. Unfortunately, there's really not a lot of information available in the scientific literature discussing the different physical risk factors or documenting exposure to physical risk factors in their clinical environment. One of the issues is it's typically difficult to get access to that environment. And so what our objectives in this study were to get into that environment and, one, characterize the frequencies and durations of some of the tasks that ophthalmologists are commonly performing, characterize the neck and shoulder muscle activation patterns using surface electromyography, particularly of the neck and the shoulder region, and then explore differences between these common clinical activities based on these exposure metrics. So what did we do? Well, essentially we recruited 15 faculty ophthalmologists from the University of Iowa hospitals and clinics, and they all were working in an outpatient clinic. And we had a research assistant follow these ophthalmologists for 2 entire work days. This research assistant had 2 primary responsibilities. One was to set the ophthalmologist up with surface electromyography equipment, and then the second was to shadow them and mark down the start and end time to the nearest second of every activity that this person did. And so then we used that information to categorize their work into 4 main categories. One is use of an indirect ophthalmoscope, which you can see on the left here. The indirect ophthalmoscope is basically a head-mounted device that is used to shine light into a patient's eyes. The second activity was use of a slit lamp biomicroscope. This is basically what it sounds like, a biomicroscope that you can use to get very close images of a patient's eye. Documenting with a computer, like any doctor, these ophthalmologists were frequently found to be documenting on a computer while they're working with their patients. And then we also used another category. So this could be things like putting eye drops in somebody's eye or using a hand tool. Maybe they're removing stitches from somebody's eye. A whole array of different tasks. As I mentioned, we used surface electromyography to measure bilateral muscle activity. And specifically, we focused on the upper trapezius and the anterior deltoid muscles. We processed this data, if I can get it to click, using some custom LabVIEW and MATLAB programs that we've developed at the University of Iowa. Specifically, we normalized our raw EMG signal as a percentage of a root mean square EMG amplitude that we observed during submaximal reference contractions. So basically, there's 2 primary methods for, at least that I'm aware of, for normalizing EMG data. One is using a maximum voluntary contraction. The other is using submaximal isometric reference contractions, and we chose to go that route because we have some other comparisons that data that we had, and then also it's generally safer and a little bit faster to complete in the field. Summary measures that we used to summarize this data included the mean, the 90th percentile of the amplitude probability distribution function, which is an estimate of peak muscular activity, and then the 10th percentile of the amplitude probability distribution function, which is an estimate of the static level of muscle activity. And these were all represented as a percentage of the reference voluntary exertion. For calculating these summary measures, we calculated over 3 different time frames. So one would be across each full shift recording. So if we collected data for 8 hours that day, we would calculate a mean 90th percentile and 10th percentile for that entire time frame. We also looked at across 8 randomly selected patient exams. So for some participants, we had as little as 8 exams completed in one day. For some, we had as many as 30 or 35, 40. So what we would do is we took that minimum number that we had for all 30 work days, and then took randomly selected 8 from every participant, so we had a balanced data set. And then the other option was for each clinical activity observed within each of these 8 exams. So here you can see on this plot, this is for one muscle. On the x-axis we have time, and on the y-axis we have amplitude as a percentage of the reference voluntary exertion. And on the left side we have exam A, on the right exam B. So what we would do is within each exam, say they're doing documentation, we would take each part of the documentation, put that together, calculate a mean 90th percentile and a 10th percentile across that clinical activity. So overall results, in total, we observed 608 total patient examinations with an average length of data collection of 7 hours each day. For a subset of that 240 exams that I said 8 exams and the 15 participants, 2 work days, so there's your 240. If we look at some of the frequency of the tasks that were completed, we can see that the computer was the most frequently, or documentation with the computer was the most frequently performed clinical activity. Completed almost 2.5 times per exam. The average duration is about 180 seconds. The indirect ophthalmoloscope was the least performed clinical activity, and the second least was the slit lamp biomicroscope. Just checking time here. If I look at some of the comparisons between activities, and I should mention that we ran these comparisons for all the different summary measures. For the interest of time, I'll just talk about the mean EMG amplitude today. But generally, comparisons, regardless of if I'm looking at the right or left upper trapezius or the right or left anterior deltoid, typically the indirect was the clinical activity of using the indirect ophthalmoscope required the most muscular effort. And this was followed by the slit lamp, and then the least most performed, or least intensive activity was using the computer for documentation purposes. So, and I should mention as well, we used post hoc pairwise comparisons for this. Generally, we found statistically significant differences between almost all of these different groups, except for in some cases, such as the left upper trapezius, differences between the indirect and slit lamp were not observed. But so generally, those are those results. Comparisons to other occupations, as I mentioned, we've done some other studies, and we're aware of some other studies in the past that have looked at full-day muscle activity using submaximal reference contractions, specifically studies on hospital cleaners and office workers, office maintenance and custodial workers, and then two studies of industrial assembly work. And generally, for those studies, the mean APDF values that were observed for the 10th percentile, which again is an estimate of static muscle activity, so about 3.6 to 21.6% of the RVE. Our estimate was at 1.4%. The 90th percentile in these studies was roughly 61 to 150% of the reference voluntary exertion. We observed 37.4. So again, the ophthalmologists appeared to have slightly lower muscle activity or muscle demands in comparison to those other workers, but that's kind of to be expected, especially considering that some of these workers are doing manual labor, custodial workers, assembly in a manufacturing facility, right? So we would kind of expect that. Overall summaries and conclusions. As I mentioned, although the indirect ophthalmoscope and followed by the slit lamp biomicroscope were the least or the least frequently used pieces of equipment in the clinical environment, they still require the greatest mean muscular effort to use. And so overall, we feel that this means that the indirect and the slit lamp are the most appropriate for ergonomic intervention. There's opportunities there to help redesign these pieces of equipment and make some changes that can help reduce exposure to these risk factors associated with musculoskeletal health outcomes. Additionally, I think it's important, or I should say it's important to note that although the indirect ophthalmoscope and the slit lamp biomicroscope required more muscular effort than, say, documenting with a computer, that doesn't mean that documenting with a computer is without risk. The high frequency and duration of these clinical activities can still lead to the development of musculoskeletal disorders. There's been a number of studies, here are 5 that have been cited in the last 10 or 15 years, that have established a causal relationship or at least indicated the existence of a possible causal relationship between duration of computer use and musculoskeletal disorders of the neck and the arm. Again, although we can redesign aspects of the work, there's still going to be risk regardless. What can we do? Well, our focus moving forward has really been on developing and evaluating new equipment. I recently published a study in the journal IIE Transactions on Occupational Ergonomics and Human Factors, evaluating some of this conventional equipment in comparison to alternative equipment. And we've really found positive results in that study. So if you want more information, you can come talk to me. Just to highlight a few things, this is the slit lamp biomicroscope, some changes that we have implemented. For example, one would be including inclined oculars that could potentially help put the neck in a more comfortable position while you're doing your work. Now you're not craning it so much. Another thing, simple things like including elbow supports or elbow pads. These pads can, 1, help reduce contact stress on the elbow. 2, they can also help put the arm in a more comfortable position. And not only is it going to help reduce possibly exposures for the neck and the shoulder, but it can also help reduce exposures in other areas. If you notice in this picture, the wrist posture in the conventional is much worse than in the alternative condition. And then additionally, other things that we can do are, although the worker's not really using the back support in this picture, the alternative back support is very adjustable. You can actually move it around the entire body. And so in some cases, an ophthalmologist can use this to help support their weight while they're doing different activities. We really could use some more research along these lines, not only in ophthalmologists, but among a large group of healthcare workers. So at this time, I thank you for your attention, and I welcome any questions you have.
Was there any effect on performance that you could detect in your study? It was mentioned earlier, as far as payback, sometimes that's an easy to sell.
Sure. I'm trying to remember. I think one possible decrement of the alternative equipment is that it took a slightly longer amount of time to set the patient up. But we associated that more with the ophthalmologist not being familiar with the equipment. We think with over time, the more they use it, that duration is going to change.
Problems with, what I noticed with slit lamp is they'll always adjust it to the patient is.
Yes.
The patient is just there for 2 minutes. They're doing it again and again during the day. So I was kind of looking at videos on this. They'd say,
sure.
One of the guys said, adjust it for what's comfortable for you because they're only uncomfortable for a couple minutes.
Sure.
You're uncomfortable again and again all day.
Correct.
And what I suspect is they're adjusting it for patients for understandable reasons.
Yep.
But if there was any talk about that, which I think your suggestion made a lot of sense,
Mm-hmm.
adjusting the eyepiece upward, that made a lot of sense. The elbow pads, those are good ideas. But one of the other things was simply being a little more selfish, I guess, in
Sure.
adjusting it to their height as
Sure.
opposed to the patient's height. Because the patient's only there for a couple minutes, and they can kind of put up with it. I wondered if that issue came up at all.
It does come up a lot, actually, and I would just say that a lot of patients that come in, I mean, we're all aware of the increasing prevalence of obesity in our society, and so a lot of people come in and they sit down, and it becomes an issue. If you look at all the pictures, really the way, if you notice, the way it's working is the ophthalmologist kind of spreads their legs and gets in as close as they can with the patient kind of in between them. And it's becoming more and more difficult to do that. So some of the other changes that I didn't really talk about, the alternative, if you notice, the tabletop is actually, it's wider and it's a lot thinner. So, you know, hopefully we can get better access to the patient, but it's a big problem. The chairs have been, the patient chairs have been changed slightly as well to help kind of, I don't know, reduce the bulk of the chair itself and kind of get the patient away from the ophthalmologist, but there's still a lot of potential there.
Any thought about having the entire process be a standing process rather than a sitting process?
So it's very ophthalmologist and patient dependent. Some ophthalmologists do things like this standing up. It kind of depends on, do I have a 6'5" male or do I have, you know, the 5'5" female? We run into that a lot where the females sometimes can stand up. And I don't mean, you know, the shorter or the smaller ophthalmologist can stand up, where some of the larger doctors, I mean, this is a male, he's probably 6'4", I think. He kind of has to crouch in there a little bit tighter.
So how did you filter out the noisy EMG from the activity-related EMG?
Well, we went through a number of different processing. First, you know, removing the transients.
What filter did you use? I'm sure you must have used some filter to...
Yes, yeah, no, we used, oh God, I don't, there was a 60 hertz notch filter to remove the power signal. I don't remember the exact specifications on the ECG filter that we used. But yeah, we went through a number of different filtering algorithms. I can show you the papers, so.
One more question.
Sure.
So maybe I missed this, but did you consider each task as like a percent of the workday? Because even if something is a higher activity, if it's a really small amount of the time they're spending, because I noticed your sample groups were quite different in number. I mean, one was like far larger than another one. With your indirect, like the three.
You're saying the different times?
Well, I noticed your sample groups had different numbers in the groups. So they were, and I didn't know if that also maybe indicated that they did one of those more as a percentage of their workday.
Sure.
You know what I'm saying? Like, maybe you have higher activity in a certain task, but if it's a
If it's not performed very frequently, sure.
Count for that. Or
Sure. Yeah. Trying to remember if because we didn't normalize across the time of the task. It's a good point. Something that I'd be happy to talk about after.
Great.
Okay.
Thank you.
Thank you.
Thank our speakers.